of Endocrine Society of India in this particular state had progressed to a great extent and doing a big service to every physicians around by providing an opportunity to share the knowledge of the experts available in the field of endocrinology. Today's the point of discussion is calcium metabolism, which is a very important aspect of the endocrinology metabolism field that we all are part of. So I wish the whole team of the Endocrine Society of Andhra Pradesh to go ahead and do such service, which is a big leap for the service of the mankind and to the society. Thank you very much.
Thank you, sir, so much. I would like our national expert, Vijay Bhaskar Reddy, sir, to speak for a few minutes.
Good evening, Dr. Hinduja. I thank Endocrine Society of Andhra Pradesh to invite me as a national expert for this program. As Professor Kaushik Pandit told, I think nowadays so online meetings are very good because we are in different places, we cannot meet often. So having these case discussions like this is very useful and it's interesting cases. It helps the education of other physicians also. So I'm looking forward to the case discussion by Dr. Praveen. Thank you.
Thank you, sir. I would like our state expert, Dr. Arak Sachin, sir, to speak for a few minutes.
Good evening, everyone. I would like to welcome our national expert, Dr. Kaushik Pandit, who is also the President-elect of the Endocrine Society of India now. And I would also like to welcome Dr. Vijay Bhaskar Reddy from Pondicherry. I also happen to have the privilege of knowing both of them for a long time. So it is needless to say that both of them are very active, and Dr. Kaushik, I have seen him for a very long time, being active academically and in a research position, and his research output is very good. And I have seen him, and it gives me great pleasure to see him today at a very prominent position in Endocrine Society of India, and so for Vijay Bhaskar Reddy. I'm also happy to see the other senior faculty from the state of Andhra Pradesh, especially Dr. K.V. Subramaniam. So Subramaniam sir is quite senior, and he is teacher to many of the people who are attending the webinar today. So a lot of his students are there. We are going to discuss a very interesting case from Dr. Praveen Naidu, and I thank Endocrine Society of India for giving this opportunity of arranging different meetings, webinars for each state chapter, and Dr. Ram Mohan has taken a very active lead in this. So with this, I would like to close my remarks, and I hand it over to the host now. Thank you.
Thank you, sir. So today our main case presenter is Dr. Banu Praveen Naidu, sir, who did his MBBS, MRCP UK Endocrinology and CCT in Diabetes and Endocrinology. He's a consultant, senior consultant in Manipal Hospital, Tadepalli. Sir has vast 21 years of experience working in very famous prestigious hospitals in the UK, and finally settled at Andhra Pradesh. So I would like sir to proceed for the case presentation.
Hi, good evening, everyone. And I would like to thank Dr. Ram Mohan and the AP chapter of the ESI who gave me this opportunity to present today, and all the big names in endocrinology, all the professor teachers. Probably I didn't got educated by you directly, but indirectly from one of the other conferences or meetings. I did attend quite a few of your teachings and been benefited from them. So now I take this one as an honor and a privilege to be able to present a case to you. And I hope this one just generates some kind of interest in discussion after the presentation. I have 40 slides, but I'm not going to talk through everything because as a senior doctors, if I say first 2 or 3 slides, you would know the diagnosis, you would know the treatment. But the purpose of why I did this presentation purely is what if that is not the finding, and what would you do next? That kind of discussion. I just want to facilitate it. So I'll do the case presentation. I'll finish everything because it's a happy ending kind of case. So, and then I will say that what if this is not the situation, what I would have done or what you would have done. Probably that's where actually I want to generate some kind of interest. And unfortunately, I've been very busy. So my presentation is very fairly limited kind of like information in the slides, not as extensive, but I can quickly tell something that I have in my mind, and probably you can just chip in and add something more to it. And I think without any further ado, I'm going to share my screen and start the presentation. Just give me 1 second. Here we go. Wrong one. Give me 1 second, please. Okay. Here we go. I hope everyone can see the presentation here. Okay, if one of you could say yes or no, then I can proceed.
Yes, sir. Go ahead, sir.
Yes, sir.
Okay, brilliant. Okay. And once again, I thank Dr. Ram Mohan for asking me to do this presentation. And even though it said calcium metabolism, that this case is entirely about a pregnant lady who came in with pancreatitis due to hypercalcemia. So not my patient directly. She was admitted under a general medicine physician with vomitings and a very mild abdominal pain. So they investigated thoroughly and found that she has got high lipase and amylase with high calcium, with high PTH. So they did the basic workup before even I went to see this lady. And looking at the patient demographics, and she has got, she's 32 years old. She's 16 weeks pregnant, primary, never had any miscarriage in the past, and nor has any significant past medical history. She never been admitted to hospital, no surgical history, not even a simple like emergency kind of appendectomy. And well, looked at the family history, nothing significant of note. And she's 32, and she's a bit tacky and slightly hypertensive at the time of admission because of a temperature. And she was essentially going towards septic. That's the reason why she was brought under general physicians first, and her initial workup showed no obstructive pattern in the jaundice, so no jaundice, no obstructive pattern in the LFTs. Lipids were normal, triglycerides were normal, TSH was normal, and blood and urine cultures were sent. And ultrasound abdomen said there is no calculi either in the gallbladder or the renal tract, or nephrocalcinosis was not noted either. So she has got a hypercalcemia and pancreatitis. No other cause was found, and no high risk behavior like alcohol excess, etc. So, and no family history to suggest any significant autoimmune to suggest IgG for pathology, etc. So, and essentially, conveniently and comfortably, we made it. Comfortably, we made a diagnosis saying that it's a pancreatitis, highly likely secondary to the hypercalcemia, and which is in turn due to primary hyperparathyroidism. And so I went to see her and asked for ultrasound neck vitamin D and phosphorus level to complete the assessment, plus to look at if we can see a parathyroid gland in the neck as an adenoma. And our priorities at the treatment is first to manage the acute pancreatitis, which is life-threatening, and we have to manage the hypercalcemia. Otherwise, the pancreatitis would flare up, and also it can lead to long-term chronic pancreatitis. And she is in the second trimester entry at the moment. So if we can successfully localize the parathyroid adenoma, we could just get her through the surgery and probably cure the situation and get her into a safety for the third trimester and further than delivery. And the sepsis management was on the top list of management plan. And I involved the other specialties where I'm supposed to do, like gastroenterologist for the pancreatitis point of view. And I did mention their management, so they didn't add much because there's nothing for them to do, like ERCP or taking the stone out. And next we spoke to the obstetrician to say that these are the medication we're going to use. They're happy, saying that, okay, continue with the IV fluids, and they're happy. And I spoke to my surgeon to say that once she pancreatitis settled, she would need an operation. So they got the anesthetist involved. And here is the ultrasound neck report. And there is a hypoechoic lesion measuring 5 into 7 millimeters inferior to the right thyroid lobe and with internal vascularity. They said the differentials could be parathyroid adenoma or right paratracheal lymph nodes. And essentially, what we were convinced was this is the parathyroid adenoma. But we cannot do a more kind of investigations like sister maybe which would have done in normal individual to see that okay, 2 scans coinciding with the 1 adenoma and no other lesions going on at the time. And during this time, we realized that the vitamin D levels were already requested prior my review, and they were back at 21.5, which is on the lower side, and phosphorus was low. I didn't have the results actually. I looked in the system but couldn't find it. And at 24 hours, urine calcium was sent, urine Benz-Jones protein was sent. These all done by the general physician, which I would not have sent it anyway with that level of parathyroid hormones. And the Benz-Jones proteins in a 32 years old lady, I wouldn't send usually. So next. The next day, when I saw her, I aggressively treated her with rehydration and even write some furosemide just to offload her from the calcium as well. But the calcium kept on going up to 13 the day after 14. And I didn't understand why this is going up and what are we doing anything wrong? And do you have to go for other medication to cut the calcium down? And when I looked back in the drug chart, unfortunately, this lady, the moment the vitamin levels were announced, one of the doctors prescribed 60,000 units of vitamin D. And that's what actually pushed the calcium up a bit for the next 2 to 3 days. So then we are in a situation where we have to treat the hypercalcemia. Hydration is not going to be enough because she was already given high dose of vitamin D. And we have a lesion. We have to confirm whether it's a parathyroid or not. So 2 things happen. One is a diagnostic. We asked for FNAC of the lesion that we saw on the ultrasound scan, which later confirmed as a parathyroid tissue. And she's a young lady. And we looked at the other reasons for hyperparathyroidism as a syndromic pattern. Luckily, she didn't have any histories of suggest of MEN1. So we believe it's a primary hyperparathyroidism, single parathyroid nodule at the moment, as far as we know. And if we could excise it, hopefully, if the intraoperative parathyroid level is less than 50%, then we thought we would achieve the successful cure for the hyperparathyroidism. That was our thought. And from the hypercalcemia point of view, we had to start some medication. And after further discussion and agreement with the patient and the gynecologist, obstetrician, we started her on cinacalcet slowly, along with the diuresis and IV fluids, which slowly got the calcium down. I'll show you all the results in a minute. And after that one, electively, we decided not to go for surgery immediately because the patient hasn't been eating for such a long time. She was feeling very weak, being treated with antibiotics. So taking her to surgery might cause sepsis might come up again with this surgery and anesthetic, etc. So we decided to postpone it for a couple of weeks until the patient builds up, because now her pancreatitis settled, her MLS lipase settled, she's able to eat, no abdominal pain, no vomiting, her bowels are okay, abdomen is soft. So we discharged her with the calcium of around 10.5 and the cinacalcet at 30 milligrams BD dose. And we did discuss actually the pros and cons of using any medication to affect the PTH or the calcium on the mother that might pass to the fetus. And following that, she went home. She did have all these medications, and at home she had a weekly calcium check where the calcium has went up to nearly 11.5, when I think she might have missed cinacalcet for a day or two. Then we got her back onto the cinacalcet at 90 milligrams in a day, 30 TDS, which controlled the calcium. And after that, on the 17th of January, which is nearly a month and 1 week following her admission, she come back for elective right inferior parathyroidectomy. During the surgery, parathyroid levels pre-op was 121, which was influenced by the cinacalcet, and post-op it was only 23, which is nearly 80% reduction, which we are quite happy saying that we achieved the complete success of the parathyroid gland removal. And the post-op period was slightly complicated as expected with the mild hypocalcemia because she was vitamin D deficient. So all we could offer was one dose of calcium, vitamin D, but we could not offer anything else because of severe hypercalcemia and the chances of recurrence of pancreatitis with raised calcium. And after the post-op, after thorough discussion, because we didn't want her to go into tetany and cause problems with her womb, we gave her some activated vitamin D for a short period of time along with the calcium, which kept her calcium good, and discharged her and weaned it off and get her into normal calcium and vitamin D supplementation. And post discharge, she's been continually sending us the calcium, and she's been very good. And a few days ago, she sent her last calcium, which was 9.9 with supplementation. And she's now 39 weeks pregnant, doing very well, and haven't got the date for labor yet, but she's near the hospital. She wants to deliver at her hometown. And what we said was, because she has got problem with the calcium, we advised for the baby to be neonatal calcium should be checked just in case following the delivery. And the mother is going to be coming back to the clinic few months after the delivery, just to get her checked, and also to see if we need to work her up with her MEN kind of condition. Just to give you the little bit of the facts behind the story. So PTH on admission on the 10th of December was 177. And during that time, this is ultrasound scan, did not show any stones anywhere. And I already showed you the ultrasound of the neck, and the calcium went from 12.3 to 13.1, and the vitamin D was around 21 at the time. This is when I think the patient was given some vitamin D high dose. And then subsequently, you're looking at the dates from 14th to 15th, the calcium went up to 14 on the 14th as a result of intake of vitamin D. Then with the rehydration and cinecalcity, it just fell down to 10 on the 17th. And then she went home, come back, had a surgery, and the 18th, on the day of the surgery, pre-surgery it's 121, post-surgery intraoperatively the PTH was 23. So then we closed the neck with the minimal invasive parathyroid surgery. And this was so easy for me to tell, but to organize this one, it took so much of time. And so if you look at it was, if you look at the calcium, this is a pre-op calcium, and post-op, she went into hypercalcemia. She was quite symptomatic, even at the level of 7.9, probably, with the pregnancy and the albumin, the available albumin is completely, we don't have the IPTH we don't have IPTH, we don't have the ionic calcium either. We were just getting the albumin and doing the corrected calcium, but when she is symptomatic, she is symptomatic. And so we had to give her calcium, and because to prevent her staying in the hospital, because at post-op the period had like a fever and stuff. So surgeons were quite worried that because she had a general anesthetic, she might end up having a big pneumonia. They want to get her out of the hospital sooner rather than later. And we kept her on the antibiotics, and I kept under my care for the post-op state, and I gave her some calcium and discharged her, and she did very well afterwards. And they advised the patient was just to make sure that the neonate after baby is born on the heel prick test, just get the calcium checked as well. And I will see her again to see whether I need to work her up from the young age hyperparathyroid presentation, whether she has got any further history. But as far as I can tell, her mother was there, and she could give me some history. As far as I can tell, she didn't have any family history that made me worry about the MEN1. In herself, she didn't have any history from the pancreatic tumors that would warrant endoscopic ultrasound at that point. I didn't want to complicate the picture at the time, because the preclinical probability is very low, and we're quite happy that we got an adenoma. There is no hyperplasia of the other glands as far as we can see. So we just simply said that it is an isolated event of hyperparathyroidism, and she's cured. But I will follow her up after the delivery of the baby. And now, from the discussion point of view, if we had left the calcium not treated, what would have happened? That's the first thing. Before we treat medication that can cause complication, now we need to look at what would happen if you don't treat her. So acute pancreatitis, life-threatening, and there is no question that you cannot simply leave the etiology behind the acute pancreatitis, which is hypercalcemia. So got to be treated. It's life-threatening. Just forget about the pregnancy. Mother life is in danger immediately. And second thing, pregnancy. During the pregnancy, with the hypercalcemia, risk of preeclampsia and premature birth is very high, and that's been well proven in quite a few of the case presentations that's been said. And because of that reason, if the patient cannot have parathyroidectomy because you could not isolate it, or she's very high risk to have an operation because they've been on some anticoagulation or DVT-PE, and most of these people have a multiple pathology, older presentation with the precious pregnancies, etc. And unfortunately, these are the people which who develop these kind of unwanted complications. And if you can do operation, then you need to use some medication and take the risk for the fetus and the pregnancy at that point. Now, calcium management during the pregnancy, I will talk it at the end of it. And usually the ionic calcium is the one that we need to look for. and we need to aim it strictly within the normal range during the pregnancy, and IV fluids and encouraging oral fluids, if some loop diuretics to encourage renal excretion, calcitonin and senocalcid. They're not very well studied, but they have their own risks, which I'm going to talk about it at the end. And IV bisphosphonate usually avoided unless until it is necessary, particularly not in primary hyperparathyroidism, but there are some occasions where a mother who has got a previous breast cancer with bone mets, etc. There are quite a few case studies where these people were given bisphosphonates, and the outcomes are showing that bisphosphonate do actually affect the fetus, and animal studies very clearly shows about the reduced birth weight for the underskeleton abnormalities at the diaphysis level. And so these kind of things we can discuss at the end. So these are the only treatment options we have at the moment, and for the primary hyperparathyroidism point of view. But the best treatment modality is essentially the surgery. Looking at the calcium levels, non-pregnant women, normal calcium level, and sorry, I'm still thinking in terms of millimole per liter, which I got used to. 2.5 to 2.6 is the normal. One standard deviation, 2.75 to 7.6. Usually people won't have any symptoms. Two standard deviation, 2.9. That's where people start to have the asthmatic symptoms and has got a polydipsia, polyuria, probably much more renal excretion of calcium that can be easily visible, and it would be more apparent and can differentiate very clearly between the familial hypercalciuric hypercalcemia and the hyperparathyroidism. And so in our numbers, I think it's 10 is normal, 11 and 12 are the 1 and 2 standard deviations, which is much easier to remember. And in pregnancy, even the slightest raise in the calcium could have an effect on the fetal calcium and the PTH balance. So, and also it can cause complications with the premature labor, etc. So it's better to keep it normal if at all possible. And if you leave the hypercalcemia longer until the delivery, the neonatal hypercalcemia is a risk where fetal neonatal tetany can happen. So, and role of parathyroidectomy. First of all, that is the treatment of choice for primary hyperparathyroidism during the pregnancy. And in these days, people are getting pregnant even with renal failure, where they have secondary, tertiary hyperparathyroidism. So 3.5 gland surgery could still be performed in the second trimester, and if the patient is well enough. Why second trimester? First trimester, risk of miscarriage and organogenesis is still ongoing, whereas second trimester, organogenesis is completed, and the patient's anesthetic risk would be minimal. Third trimester, high risk of premature labor. So the ideal time to do a parathyroidectomy is second trimester. And the role of parathyroidectomy, essentially, adamantis, when do you say that parathyroidectomy is successful? The intraoperative PTH changed quite a bit, because when I was a registrar, intraoperative PTH was not available. And during that time, people used to say that so-and-so center practices it, America practices it, and their like success rate of the parathyroid is like a pretty good. So what happens with the intraoperative PTH? If you see the intraoperative PTH drops more than 50%, the sensitivity is around 85%, and the specificity is nearly 100%, saying that, okay, the positively we carried out the culprit lesion alone, and there might not be any other lesion left over. If you say that PTH dropped nearly 80%, the sensitivity to specificity reaches 100%. So that means you can say that you don't need to do the bigger neck exploration and longer healing times and more trauma. And so it is essentially, it makes the minimal invasive parathyroid gland surgery successful. But for that, you need to isolate the gland that is actually culprit. So what are the modalities that we use? One is ultrasound. The second one is system AB scan. Combined to this, you get much more sensitivity. If you fail to find in this system maybe with the SPECT CT, then 4D CT, which is contrast CT in 4 phases. One is non-contrast, arterial, venous, and late venous phase. And if you do that, chances of picking up a parathyroid lesion is quite high. But I do have a patient, band or primary hyperparathyroidism, all results are normal, but I think we might have missed the interthyroidal parathyroid, and the system maybe might have been a cock-up. So I'm going to repeat all of them. So there are exceptions for everything, but these are the ones which are available. But most of the times you do find the lesion pretty comfortably. And if localization is not possible, our experienced surgeons can do the next exploration. But one the caveat with this is, what if you got an ectopic site of the parathyroid? And where do you see the parathyroid? And upper parathyroid, superior parathyroids are usually posteriorly located next to the esophagus and trachea. So it can be in the tracheal gutter or esophageal tracheal groove. And if you look at this diagram, it just clearly gives us an idea of where the ectopic parathyroid can be. The inferior ones usually on the anterior. It can be in the within the thyroid or in the thymus or in the superior mediastinum. So these things are usually picked up on the CT scan, which you cover until the inferior mediastinum. So next one, because this is a lady hyperparathyroidism, 32 years old, we found an adenoma very clearly. It's not a hyperplasia. We found an adenoma because it's reasonably big in size, whereas parathyroid is hardly like a few milligrams of weight, and it's a reasonably big one when we found it on the ultrasound scan. So we're happy that it's an adenoma, and she doesn't have any other history, but could it still be MEN1? And because if you ask anyone, a person who comes with chest pain, ask them, as anyone in your family has got a heart attack, they say that no. But if you just simply meet the person, they say that, yeah, I had a heart attack. So in our families, not many people know the complete medical history of their parents or grandparents. So there is a high chance and that they might have got a condition. They were not diagnosed. They just suffered it throughout their life and they died. So this is the reason why the history and family history, we have to be like detective, but nonetheless, our chances of getting full history might still be very low. So if the suspicion is high, if the patient has got more than one symptom apart from hyperparathyroidism, I would have been very, very inclined to do a MEN screening for a young lady, because MEN usually presents in the second and third decade of the life. And usually these people won't be symptomatic for a long time. And so whatever the symptoms they present with, and particularly before the fourth decade of life, probably I would be more inclined to do the genetic testing, particularly if they are relatively cheaper nowadays. And MEN2A is another one which is very, very useful. And when we did the ultrasound scan, we did not see any thyroid suspicious nodules to suggest medullary. So we are quite happy saying that she's young to be, because usually MTA, unless until it's a very classically familial going on, I wouldn't be worried too much in this case. So this is another picture just to remember this MEN1 and 2. Now, next thing is, okay, I'm suspecting probably MEN in this case. What kind of investigation I would be thinking to localize this? Sorry, this is one. And so one is, we have two modalities here. One is a nuclear medicine scan, which is 99 technetium system maybe scan. And the second one is a CT scan, 4D CT with contrast, or just a CT scan to look for any abnormal lesions that are present in the area where you could find a parathyroid. But are they safe for the fetus? Outrightly, they're not the best in general, but there are some situations where if the mother's life or the fetus life or both their lives are at danger, and you want to look at it so that you could do a successful surgery for a better outcome, what would you do? And in this scenario, that we need to get a little bit more, learn a bit more physics, which is how much of radiation is too much of radiation for a mother or a baby? Because I've done so many low contrast CTPS for mothers, because at the time you have to rule out that condition. That's like not an option because the risk is high. You cannot simply anticoagulate them just thinking a diagnosis. So we did the scan. So we do have some idea about how much of exposure is too much and how much is not is safer. And in general, after looking through quite a few papers, what I found was, and to be honest with you, I have to admit, I do not know the power of these units. And it says gray. It's a MGY means it's milligray. These are the units that they are counting the radiation. So if the cutoff for any mother can expose herself during the pregnancy, the fetus is 50 milligray. That is associated with growth restriction, anomalies, or probably cancers in the long run. And so we have to make sure that they're not any closer to that level of radiation. But if you look at a simple scintigraphy with a low radiation, you can get them less than 5 milligrays. There are so many case studies where the women had this low dose and they didn't have any fetal anomaly. And also the 4D CT, and just very similar to the milligray is millisievert. And I think one is functional, one is a unit. So I do not know the exact difference, to be honest, and I didn't have time to read about it. So essentially, this is essentially low. And there is another one is when you do a 4DCT, you have to give contrast. So that contrast related damage to the fetus also need to be taken into account. And so if the condition at operation with a successful localization is going to be very useful for the lady, and the benefits outweigh the risks, I think we can in that situation suggest to have these tests to localize the parathyroid adenoma, and afterwards a successful parathyroid surgery in the second trimester of the pregnancy. So moving on, these are just simply, I found some case reports about it. And if it is an MU1 lesion, if you find a parathyroid as a hyperplasia, not just one gland, what are we going to do? And it's again the same rule. The PTH, intraoperative PTH has to be less than 50% after you operated. If there are 4 glands hyperplasia, you might do 3.5 gland surgery, or you might stop it at 2 gland surgery if the PTH falls, because you already identified the bigger ones among the 4, and you just simply take them out. And that means those are the ones which has got genetic mutation and causing the hyperparathyroidism. So this is actually very helpful to have intraparathyroid hormone assay during the surgery, just like a frozen section. So you can make decisions in the real time very quickly without causing too much of hassle, and it prevents the patient to have a second surgery in the future. And now coming to drugs, and already spoke about cinacalcet. Cinacalcet is useful. We used in quite a few pregnancies and primary hyperparathyroidism, elderly patient who cannot have surgery successfully. But in pregnancy, does it work, and is it good medication? And essentially, we do not know. And the reason being is the number of people that we saw over a period of years since we used the cinacalcet, because our experience with parathyroid cancer and cinacalcet is reasonably good, and experience with untreated non-pregnant hyperparathyroid is reasonably good. But when it comes to pregnancy, now we are so good at just identifying and taking it out much quickly. So our experience with cinacalcet is not that great, but we're using this one in a cases like the ones I've seen where patient cannot have surgery then and there, but the hypercalcemia is causing too much of harm to her at the moment. So we have to use some medication so that we can keep her out of the harm from hypercalcemia point of view. And when she's safe, we get the surgery. So cinacalcet is a choice during that time. And what are the side effects that you can expect? I found these ones. This is published back in 2014, and these studies were done quite a long time before that. So 4 case presentations and 4 papers, I think. As you can see, the number of patients that they saw was not great. And essentially, the one lady, 28 weeks gestation, 60 milligram BID dose was given. Her calcium level was satisfactory at the time. And our equivalent normal is 2.5 is 10. So 2 is essentially 8. So the millimole was normal. So when the calcium is well controlled with the cinacalcet, the fetus did not have hypocalcemia. The baby didn't have hypocalcemia. That's a normal calcium. What that means? If someone mother has got hypercalcemia, that is being represented in the baby's blood, and PTH crosses the placenta. So the fetus PTH is usually suppressed by the time. So if we have like a medication that keeps the PTH relatively lowish and calcium relatively normal, the baby calcium homeostasis is maintained. That's what it simply means. And if you look at the second case, the very small dose is given. She's maintained between the first and third standard deviation. That means it's a relatively higher calcium level, but because it's a preterm labor, before they could escalate the doses, the labor happened. The neonate actually suffered hypocalcemia. And as far as I can remember in the case study where I looked at it, it could be a tetany. And at in the next one, 31 weeks, 30 milligram BD dose of cinacalcet delayed hypocalcemia because the calcium control was not so good. And if you look at the other case, it's the same. High dose calcium control was not good. It's a preterm labor and hypocalcemia. So these people who has got hypercalcemia, for whatever the reason they were having, they're higher risk of preterm. And these medications are not so good because they take time before the work. And the chances of neonatal hypocalcemia is there if the calcium is not well controlled. This is the reason why, if at all possible, do the surgery. And that would be helpful for both mother and the fetus and the baby. And this is about the cinecalcet in parathyroid, primary hyperparathyroid. Sorry, the print is so small, I can't even read it from here. So, and there are quite a few studies saying that they used it along with the bisphosphonate, so that primary hyperparathyroidism has been successfully treated in a non-pregnant patients in a cinecalcet at the maximum dose of 120 BD. But it's an expensive medication in India to continue for a longer time. Okay, so from the cinecalcet point of view, there is one more thing I want to say, but I'll come to that later. Okay, and moving on to calcitonin. Calcitonin is something we all know. And in India, I did not find the subcutaneous dose, but we have the nasal calcitonin, which is nearly double the strength because the absorption is only 25%, the bioavailability is 25%. So I think we might have to give the double dose. And calcitonin works very well for immediate calcium reduction. We can use it in pregnancy if it is a life-threatening emergency from the hypercalcemia point of view. And it can bring, particularly if you give the adequate dose, 1 to 2 milligram per deciliter within 4 to 6 hours. But unfortunately, whatever the improvement you achieved won't last too long because the osteoclastic activity that it prevents usually gets dimmer and dimmer as the time goes on within 2 to 3 days because the osteoclasts become less sensitive to calcitonin. And if you're using a subcutaneous at 200 units, you started BD for the hypercalcemia, and then you work it up to increasing frequency up to 400 units every 4 hours if necessary. And then within that time when the calcium is normal, you need to do what you need to do afterwards so that at least you won't get the rebound of the calcium again. So, and is it safe during the pregnancy? The animal studies, particularly on the rabbit, showed that the fetal birth weights are relatively lower, but this wasn't actually shown the same in the human data, but the amount of data we have is quite minimal. So we cannot simply comment, but essentially, if it's a life-threatening hypercalcemia, you want to use calcitonin, you have to use it during that time because you're running out of options and both the mother and fetus life is in danger. Otherwise, you have to exercise caution and try to avoid this medication if at all possible. And if you can sort the calcium in a different manner. And there are other uses in non-pregnant women for calcitonin, quite a few. And first of all, somebody who has got osteoporosis, take a fracture and very severe back pain, calcitonin is the way to go. And most menopausal not tolerating any other medication for osteoporosis, this can be used as a bridging therapy before you decide on the right therapy. And there are like quite other some migraine people have used it, acute bone loss when people have been hospitalized, and you can use it temporarily. So you can use this one as an off-label. And Paget's disease, this is used regularly as a subcutaneous injection. So calcitonin is very useful medication. We have I think only nasal spray I found so far. So moving on. Sorry, I thought I did write the bisphosphonate, but it didn't. Sorry, I missed that one. And bisphosphonate, we all know we use it for hypercalcemia, whether whatever is the origin, it works, and it's a primary hyperparathyroidism or non-PTH related. But giving bisphosphonate in a pregnant woman do have some side effects. The diaphysis, which is a growing bone for the fetus, can be affected with the bisphosphonate. So the bones are smaller, so birth weight of the baby would be smaller. There are some case reports where the mothers had to be given IV bisphosphonate for the malignant hypercalcemia, and some people, particularly who is having a breastfeeding, has to be given this one for their general health, for some medical conditions they have, and they found that within 48 hours, the breast milk is free of bisphosphonate, but within that window, 48 hours, we do see bisphosphonate in the breast milk. And from the mother's point of view, it does affect the fetus growth, and bone skeletal anomalies can happen. And hypocalcemia for the fetus is the main risk that noted. And also, if the hypocalcemia happens for a lady who is about to be having a delivery, the atonia of the womb and the contractions can be compromised, leading to prolonged labor and suffocation for the baby and the baby distress, the fetus distress. So because of that reason, you have to exercise even more caution with the bisphosphonate before you use it in a pregnant woman. With that, I finish my presentation, and I hope I did cover most of the things starting with my case presentation, but I'm quite happy to answer if you guys got any questions or query, and I would be quite happy if you could share your experiences or want to add something. on this
Thank you,
topic.
sir. Thank you. Thank you for your excellent and detailed presentation, for sharing your experience. I would like our national expert, state expert, and guest of honor to discuss about these cases or add anything.
Thank you, Dr. Praveen. I think it was an excellent case. I think very challenging. I think each step by step you showed how you went through. I think we have to improvise and manage the case. I would like to share one case where we had pancreatitis, but the initial calcium was normal. Patient had pancreatitis. The initial calcium level was normal. So even during acute pancreatitis, even when the calcium is normal, it does not rule out hypercalcemia, because during the acute pancreatitis, there can be this fat saponification. Calcium gets deposited. So calcium can be falsely low. So even if you get a normal calcium, you have to repeat the calcium level after the patient's acute episode is over. So you may get a falsely normal calcium during an episode of acute pancreatitis. This is one thing we should remember. Lucky for you that the calcium level was high, so there is no confusion. But the calcium can be falsely normal because the pancreas, there is fatty necrosis. The calcium can get saponified there. So we had one case where we had this, and the calcium level started manifesting a week later, and then we got on to the job. So another one is for the localization, how good is MRI? Because MRI is relatively safe in pregnancy than CT scan. So there is some 4D MRI, but that's not easily available. So that's 4D MRI is one thing which we can consider, but that's not easily available. So that is also further investigation is challenging. The last point I would like to make is in case the patient is not fit for surgery, do you have any experience with minimally invasive treatment option like ethanol ablation or micro-invasive ablation, microwave ablation of the parathyroid? Thank you.
Thank you, sir.
Recently, there was an argument about using a chemical kind of ablation of the PTH, parathyroid gland. I think it was in one of just a few days ago. It's been mentioned. When we do the ablation of the one parathyroid gland, there is a quite high chance that we might miss the actual cells that produce the PTH. And this is one of the things. And I think, look actually what the people said, ablation, because if I type it, I might find it. I found that interesting because this is not an area where I have any experience. I don't even suggest ablation of the thyroid glands recently because of the false negative thyroid papillary cancer reports that I've seen. So I think probably I'm just going on a caution side. This ablation in a functional, right, okay, so here we go. So I don't know actually who commented on it. The possibility of incomplete ablation in a functional tumor would be a deterrent to use this kind of method. So this is the problem. And if the PTH adenoids are less common and difficult to visualize, but for example, if they're, okay, sorry, I think they were just having their thoughts typed out. This is exactly what he said. And I'll give you a few examples. You mentioned about the MRI. And if I see somebody who has got primary parathyroidism and they got negative scans, I wouldn't say that they're negative scans. They were reported wrong. Okay, that's the most important because radiology is one of those like a fields. Unfortunately, if you go and look back, you can always say that, okay, the lung cancer was sitting there 10 years ago or 5 years ago. Nobody picked it up. It was so indolent. And this is one of the reasons why the AA is going to take over the radiology much, much better because it's going to give all the false positive and we end up doing more investigations in the future because we're doing the safe medicine practice. And we see that quite often. I saw insulinoma recently, which has got a pancreatic lesion, 1 centimeter. I could see myself in the arterial phase, and that's been reported as a normal pancreas. So it's not a negative scan. It's a wrong report. And if we have a 4D MRI scan, if the radiologists are not experienced in reporting it, there is no point doing that scan. If they are very good at reporting CT, I would do the CT because I need an answer. I don't need a fancy scan. And this is what's happening in this part of the world. we do not have as much expertise as I worked with in the past. And in the past, I go and see a neuroradiologist. He tells me the diagnosis. He doesn't tell me what he found on the MRI scan. He just put everything two together, and he says that the possibility of this diagnosis is very high in this situation, and the differentials come to this. So that made my life much easier. Now here I have to work, and I even have to learn interpreting the scans now. I do interpret my own scans these days. I don't do thyroid because of the, the litigation with the malignancy and the number of false positives, I might say. And but I just want to learn that one too in the future in case if I get time. And unfortunately, the false reporting is the one. I just told you one example. I have one patient with the band or primary hyperparathyroidism. I'm managing her on cinacalcet because I could not locate that one. We did a 4D scan in our hospital. And when I called one of the radiologists, and he said that, what is 4D scan? And he reported when it's a angiogram report. It said on the top. So the radiologist doesn't know why he was reporting that scan. This is the problem we have in this part. So I had to go and tell them. Luckily, one of my classmates from Usmania, who is I think he's just one rank before me when we went to Usmania. So we used to sit together. He's a radiologist, very nice one. I sit him after 5 o'clock. I show him all the scans. I learned something from him. And this is what's happening. In the diagnostic radiology, we need a good radiologist who are super specialized in the one sect. And we need to keep seeing him so that we can get more experience. What is the difficult part in managing this case? It is not the patient counseling. Patients didn't say a word throughout this because they saw me. I said that this is your situation. This is how I'm going to manage. And I spent 2 minutes with them and I gave the plan, went home, come back next day, found that she was given some vitamin D after 2 days. So this is the problem. And all I would saying at the moment is patient didn't have any problem. They're listening to me, but counseling the the anesthetist saying that it's such a simple operation, telling the surgeon saying that it's very simple. I manage the pancreatitis. I do general medicine as well. And I managed this one, hyperparathyroidism. So it's very simple. Do the surgery. They said, no. Let's send her home. Bring her back in 2 weeks' time when she's stable. I said, okay, we can do that. It's not a problem. I send her home, bring her back. Otherwise, I would have got everything sorted in one sitting because she was a reasonably healthy lady, young lady, simple hyperparathyroidism. Unfortunately, ended up in mild pancreatitis. And we would have sorted it straight away. But it took 1.5 months for us to sort everything out. Now she's delivering baby probably in a week's time. It's a success story, but we can see so many things might have gone wrong. Yet they've gone to different hospitals. So, and expertise from radiology point of view, I'm lucky that I have somebody close to me sitting next to me. So I'm getting most of my stuff done by him, and we're getting good things. And we're doing even AVS, etc. here in our hospital with intervention radiologists, but their expertise is not good. We have to supervise them closely. Otherwise, they might document left to right, right to left, and the purpose of AVS must have been completely doomed. So we have to be very careful here in this part of the world, I'm afraid. And I'm a bit cynic, but I learned it by the hard way. So there's no other way I can be now, unless until I was reassured by my colleagues, being more thorough and professional.
True, sir, what you said is true. The cases which need a multi-department approach or involvement are very difficult to handle.
That's correct. And most importantly, when they come and say that by the time I go and see the patient next time, there was 24 hours urine being collected and vitamin D was given, myeloma screen was done. I was saying that, okay, your textbook knowledge is pretty good, but completely irrelevant to this condition. But she wasn't my patient. I was reviewing the patient as a referral. But good thing was I took over after she got admitted for the second time. And it was a good case. As you know, mothers, they do listen to whatever you say. That's a good thing. And this is one of the good thing with managing gestational diabetes. And you achieve as good blood sugar says in majority of the patients because they listen to you. The same thing happened with this lady. I said, you need to take this medication. It can cause a bit of nausea. And half of the time, cinacalcet doesn't work because mothers can't tolerate it. It causes more nausea when you get up the dose to beyond 60 milligrams per day. And that's one of the reasons why it fails. And not just it's not effective. It's very good calcium mimetic. But unfortunately, it's expensive and high doses can cause nausea. And in pregnancy is one of the periods where mothers won't feel that great all the time, every day. So but she did it.
Yeah, I think that was a great case, Dr. Praveen. It was very interesting. And I must say, I'm thankful that I haven't had to manage hyperparathyroidism during pregnancy. Difficult problem, but thankfully you have managed it very well, and the patient must be really grateful to you. It was an interesting case. The radiology problem that you face is, I think it is because probably your setup is small. So if you go to, it is not the problem of the part of the world. The problem is that you have probably gone to a smaller setup than the setup in which you were trained. So that happens to a lot of us, that we train in a very big hospital, we go to a smaller setup, and then we try to compare it to the setup where we are trained. So that I think is a problem, your local problem. I don't think that that is a general problem. And I find in my setup, I find that we have some very good radiologists who are able to give answers. Thankfully, I haven't had to go and sit with them to see the scan. But anyways, you have managed it very well, and I think it is very good. And the experience of Dr. Vijay Shekhar, I find it interesting. So I haven't had any experience in the alcohol in the ablation of parathyroid adenoma. But I agree that in thyroid, I am a little bit cynic, but in parathyroid adenoma, I might still think about it. Functional reason, and as you have told about intraoperative PTH, here also it will be possible if you are monitoring with PTH, you will know whether it has worked or not. So maybe you don't, it is not intraoperative PTH, you can follow with PTH over next few days and see whether PTH is falling or not. If it is not falling, you try again. Otherwise, if it fails, always surgery is always the option. The last fallback is always surgery. Anyway, it was a good case, interesting and quite instructive.
Thank you.
The purpose of intraoperative PTH itself is to improve the success rate of cure. So that means if the PTH hasn't fallen, from minimal invasion, the surgeon explores the rest of the 3 parathyroids. And if they see anything is hyperplasic, they take it out. And if they have to do 3.5 or 2 glands, they do it. And if the more than 1 gland is involved at the time, majority of the surgeons come back to me to tell me that because MEN, one of the features is more than 1 gland hyperplasia. So this is one of the reasons why I always involve. And I've worked with a very good surgeon. He's a breast and endocrine surgeon, Mr. Maddox. He's the one who taught me how to do the thyroid, the FNACs, etc. The way we used to do blindly is completely different from the way the radiologists do it, because they do it only one angle. We used to go to all 4 angles and in the depth as well, so that we never missed a malignancy. And here we are missing malignancy because they're going through the ultrasound, get only one part and saying it. So with working with the surgeon has changed my practice so much, so that I know what the surgeon thinks very clearly, and surgeon must know what I'm thinking. So that kind of understanding we had ever since I was like a ST1, and I did until ST5 before I became a consultant. So having worked with him quite a few years helped me. And because of that, in hyperparathyroid things, I didn't have a failure so far in this 13 years I've been in endocrinology. But first time I saw that I could not look at a parathyroid in a Bangalore primary hyperparathyroid, and I'm working on it now. And I don't know where actually we are going wrong. Now I'm about to speak to the nuclear medicine, which we don't have in our hospital, but one very good person is nearby, and he's gonna see to it, saying that he's gonna repeat the system maybe to see whether he can see any intrathyroid lesion we might have got missed. And yeah.
Praveen, I mean, congratulations for a brilliant presentation of an interesting case. I understand that it's quite a challenging situation, especially because of the presence of pregnancy. And I can just add one point, probably you have already mentioned, what Dr. Vijay Bhaskar Reddy, my good friend, had already said, that at times, merely having a normal calcium level might be, I mean, not unraveling the situation of hypercalcemia. This happens during, say, during pancreatitis. This also happens during pregnancy as well. Because in pregnancy, you all remember that there is an expansion of the extracellular fluid volume and thereby reducing the albumin. So having a total calcium measurement might not many times unravel a situation of mild hypercalcemia. there, as you have said, that though it is not very available, that ionic calcium measurement would unravel the situation of a mild hypercalcemia. So that's also a challenge. So somebody who is having a sort of normal calcium during pregnancy might be having a possibility of having mild hypercalcemia because of some reasons. The other situation in pregnancy is that there is an elevated PTHRP, which can also at times lead to some bit of benign hypercalcemia, which really does not have any pathological significance. So these two minor issues that we probably also has to be taken into account while we are dealing with hypercalcemia with or without pancreatitis in a situation of pregnancy. Thank you very much. Yeah.
Thank you, sir.
Let me just pose one question to the national expert and guest of honor, that I haven't worked with ionized calcium, but are any of you working with ionized calcium? I tried to start it in my lab long time ago. For some reason it failed. The electrode did not work. So I'm just curious, who is working with ionized calcium in India?
Not that I know of. At least there is not the practice in this part of the country.
So I also don't use that. I think mostly inpatient setting we will require ICU and other places, but I'm just doing outpatient practice, so I don't do ionized calcium myself.
We have one with ABG, but that's not reliable, sir.
Yeah, I also see the ionized calcium report with the ABG. So I have not asked my biochemistry lab to start it, but maybe at some time we should also think about it.
Have luck. Does any other doctors have any doubts or anything to share with us? You are welcome.
The point I would like to make is, I think one of the recent papers is there from PGI Chandigarh. They have discussed about this guide. They provided some guidance about management of primary hyperparathyroidism in pregnancy. I think it was very good. So they have taken a cutoff value of calcium of 11.4. I think anything more than 11.4 milligram per deciliter, then it can cause the hypertension and adverse fetal effects. So that is one of the cutoffs where you can consider for surgery in the second trimester. So anything 10.8, 11, we can still manage conservatively, but anything more than 11.4, they recommend that we do something definitive for that case. So 11.4 is one of the cutoffs. Do you agree with that, Dr. Praveen? 11.4?
From what I read, but what I read was all the free journals. So I didn't have any access to the paid journals for the last 3 years. I got up-to-date access, but not to the JECM or the Endocrine Society or the Thyroid Societies or any other societies. If it is new that they come to that conclusion after looking at thousands of patients, then probably what they said is right, because we always will be want to treat kind of mode all the time when a patient comes to us, particularly if they're pregnant. And like your thyroid nodules, we always want to do something about it. But sometimes, as you said, if the evidence shows that it is better to step back because you're causing more unnecessary stress to the person than actually doing any good, then I think as more evidence evolves and more cases being managed successfully, I think we'll be more confident. But until now, if I see somebody, I don't want to deal with the same patient with hypercalcemia in the third trimester. That's my motto. So I would just treat it.
I'll share that paper with you through Ramu.
That would be great, sir.
Sure.
I request KAV, sir, to talk a few points about your experience.
Always in pregnancy is a very difficult condition to treat. Always, whether it is hypercalcemia, hypertriglyceridemia, whatever it is, especially when somebody is presenting with pancreatitis. The approach and the way Praveen has discussed is very robust and very nice to hear. Only thing is certain values, as Bhaskar has pointed out, it will be always there is a point of discussion. See whether at what level hypocalcemia we wanted to treat and at what level we have to leave it so that it will stimulate the remaining parathyroids is again somewhat conjecture, and it depends upon the individual. But what personally I feel is that these cases should be taken up by individual case by case, rather than having a fixed value or fixed guide. Definitely, guidance will tell us, and experience of the others will definitely tell us and guide us. But I think we have to depend upon that particular case scenario to properly treat the patient. That's what I feel. Thank you. Thank you very much.
Thank you, sir. So, anyone has something to add?
Another point I would like to make is, in case we are managing these patients conservatively, clearly we should give guidance to the obstetricians, because calcium is written routinely for all the cases. So we should advise them not to prescribe calcium supplements in this case.
And I think that's exactly happened in this case, sir. Okay, I didn't think in that way. I thought I saw the patient, I gave the management, so they would stay still. But what happened was, because of the hypervitaminosis D, as you know, fetal bone formation and all these things that's been taught to the general physicians, the moment they saw the hypervitaminosis D, and they just gave the treatments right away with the high dose, and as per the obstetric guidelines or something. And I didn't actually say anything to them. All I said was, okay, we know the reason why the calcium is going up, so we don't have to be too much panic, but we have to use some medication now, which I wanted to avoid. That's all I said. Okay.
Similarly, I've been managing diabetes in pregnancy for a pre-existing diabetes case for 5 years. And the patient suddenly comes with a GTT report at 6 months. I say, why did you do GTT? Sir, my sugar is 250, suddenly it's gone up. And on insulin, and the patient is well controlled. Suddenly at 6 months, they come with a GTT report. So reflexly, the obstetricians will be doing. So in this type of case, we should specifically tell, please avoid calcium supplements in this case.
Sir Ramon, sir, anything to add?
Ramon, you're on mute.
Yeah, nothing. It's wonderful that we had a very great discussion. Thank you, sir. Thank you, Praveen. So we had a great discussion. Thank you, all the faculty. Thank
So we conclude today our 5th webinar of ESAP session by thanking the speaker, guest of honor, state expert, national expert, and all the senior doctors for sparing their 1 hour valuable time. Thank you, everyone.
Thank you very much.
Thank you very much.
Thank you very much for the seniors for your inputs. Much appreciated. Thank you.
Thank you.
Thanks for
Thank you
doing
very
this.